Hello, everyone. Welcome to this panel discussion on rising up to the challenge posed by spinal cord injuries. This panel discussion has been organized by Spine Wellness and Care Foundation. Since there were queries on what this foundation is, we give you a brief about it. Spine Wellness Care Foundation is a charitable, non-governmental organization. We reach and serve persons affected with spinal-related ailments, medically and socially, to help them lead better lives. This was established, as I mentioned, for improving the wellness of people with spinal ailments in India, with the objective to provide medical rehabilitation, vocational, recreational, and social support for persons affected with spine and related ailments. Thus, individuals can reach out to the foundation for advice or consultation or support in any form, whether aids, appliances, vocational rehabilitation, recreation, or a barrier-free environment at home. And we would be happy to collaborate with associations, NGOs, and corporates on awareness or educational events like symposiums, talks, etc., wellness and health checkup camps, and advocacy activities. Our website is www.spinewellnesscarefoundation.in, and we can be reached on the email spinewellnesscarefoundation@gmail.com. Coming to the panel discussion today, we have been discussing about the challenges posed by spinal cord injuries, but we thought it is high time that we brainstorm and deliberate on how to rise up to the challenge posed by the spinal cord injuries. We are lucky to have a very esteemed panel today. Dr. Sanjay Wadhwa is Professor, Department of Physical Medicine and Rehabilitation, AIIMS, New Delhi. He is renowned nationally and internationally for his achievements and his foresight. Again, Dr. G Balamurli is a spine and neurosurgeon in Chennai, India. He is the consultant spine and neurosurgeon at Kaveri Hospital and managing director at Hamsa Spine and Brain. He is an adjunct professor with Sri Balaji Medical College and Hospital, Mylapore, Chennai. Dr. Henry Prakash is Professor, Physical Medicine and Rehabilitation, Deputy Medical Superintendent, Christian Medical College, Vellore. Then we have Dr. Narkeesh Arumugam. He is Professor, Department of Physiotherapy, Punjabi University, Patiala, Punjab. They say nothing for us without us, and hence we have a very elite group of panelists from various consumer associations of the country. We have Mr. Shivjeet Raghav, who is the Vice President of the Spinal Foundation and President, Spinal Cord Society Consumer Committee, Peer Counselor and Patient Education Coordinator, Indian Spinal Injury Center, New Delhi. We have Dr. Ketna Mehta, who is the Founder Trustee of Nina Foundation, and who engages substantially in advocacy activities across the country. We have Dr. Komal Kamra, who is Associate Professor of Zoology, Khalsa College, University of Delhi, and also the Dynamic Secretary of the Spinal Foundation. Hence, we come to the panel discussion. Spinal problems are one of the most frequent causes of loss of function, ranging from acute low back pain to permanent disability due to spinal cord injury. Though the burden of spine care is omnipresent, it is the underserved areas that take the biggest impact. Socioeconomic, political, ethnic, and cultural factors lead to the poor availability of spine care in underdeveloped regions. Low-income countries face 56% of the global disease burden, but account for only 2% of global health spending. We did this study on influence of socioeconomic status on access to different components of spinal cord injury management across the Indian population, and came to the conclusion that financial constraints affecting all components of SCI management in all except the upper group. The results of the survey suggest that a very large percentage of the Indian population would find it difficult to access comprehensive spinal cord injury management. the average GDP per capita of Indian population is far lower than the global GDP. And as per the World Bank, a third of the Indian population falls below the international poverty line, and 2/3 live on less than $2 per day. The public spending on health has remained low. Health insurance coverage is only 10% in urban areas, and private out-of-pocket expenditure on health are amongst the highest in the world, as estimated by World Health Statistics. So the financial factor leading to non-treatment of ailments in India has doubled, and the situation seems to be grimmer in the rural areas. Borrowing or sale of assets, ornaments, and brought animals was observed to be double in the rural hospitalized cases as compared with the urban ones. Because of lack of spine care in underserved areas, people often storm through an unending downward spiral on various aspects: physical, psychological, economic, and so on. Many developed countries have set up a robust spine healthcare system, and their best practices may provide a clue to possible solutions. Hence, there is a need to develop long-term region-specific realistic goals and brainstorm on strategies to improve access and quality of spine care to underserved areas. And hence, the purpose of this panel discussion. So the first question to the panel is, can best practices and key points from developed countries which have a robust spinal injury care system be just implemented in underserved areas to overcome the challenges posed by spinal cord injuries? Or should strategies be adopted and individualized based on the local needs and availability of resources?
We need to have our feet on the ground, but we have to look after what are the best practices. So as there is a WHO slogan that think globally, but act locally. So if we have limited resources, how best we can have the best practices of the developed countries and look after the needs of our set of persons with spinal cord injuries locally. Their needs are individualized, although there are certain common needs of every person with spinal cord injury. The needs for prevention of pressure sores, urinary tract infections, and other complications. The needs for stabilizing the spine and improving the mobility status, independence in day-to-day activities of daily living, preventing the complications, whether these are urinary or respiratory, and promptly managing autonomic dysreflexia by recognizing the early signs and all. So there are many challenges, but if we have a systematic approach and well-established protocols which are evidence-based, we can certainly move ahead. We can develop a network of various centers which are looking after persons with spinal cord injuries. Unfortunately, we are lacking in networking also. So my humble suggestion is, if we pick up 3 areas where we have to work urgently on priority, first will be proper and accurate documentation of the findings. The spinal cord injury person needs to be evaluated in the beginning as thoroughly and comprehensively as possible. And fortunately, we have the international system of assessment and recording of the findings. Second thing, we should reduce the time taken for the person to come from the site of injury to the site of first primary medical care. And thirdly, we should train our manpower, which is involved in care of the persons, be it orthopedic surgeons, spinal surgeons, the therapists, the other group members, physiatrists, orthotic prosthetic people, and all. So it is a teamwork, but we have to make a beginning. And my suggestion is, let us identify these 3 areas and simultaneously raise the level of awareness in the community by making use of social media, print media, TV, electronics, etc. Thank you.
Thank you, Dr. Sanjay Wadhwa. Very important points and very pertinent points on the way forward in this regard, and how to rise up to the challenge posed by spinal cord injuries.
Thank you.
Yep. They say nothing for us without us. So the consumer perspective is very important, and we have a very strong voice in India today for spinal cord injuries through various foundations. And we have here the representatives of the Spine Foundation and the Nina Foundation. So let me request Shivjeet, my colleague, to also give his viewpoints in this regard.
Thank you, Dr. Chawla. And in a way, Dr. Wadhwa has explained the answer to this question. And the second part itself, that should strategies be adapted and visualized, gives the answer to the main question. You see, even in India, when we talk of protocols, you will see the difference in the persons from rural and distant places and remote areas and the people who are from urban setup rather. You see, till the goals of the international policies or national policies regarding spinal cord injury, the protocols remains the same. The main goals is to achieve a good quality of life for everybody. But straight away, what is there in the Western policies and protocols can't be implemented as 100% or as it is. It has to be adapted to the Indian context or Asian context, Southeast Asian countries. Those changes are must. Secondly, you see the difference is that in abroad, everything is state funded, most of the things, which is not the case in our Indian context. And secondly, you see the socio-economic or the cultural background is totally different in our country, the population of spinal cord injury. So obviously we need to formulate protocols and ideas and things around those issues. Who needs what rather? You see, a person may be able to find a good wheelchair, a powered wheelchair, but a urban a person from very remote areas, very poor socio-economic background may not be able to afford that. So one question is no doubt affordability. So low cost and quality feature needs to be understood very well. Same is in the initial care. You see, Dr. Wadhwa mentioned that we have enough spinal centers or good trauma centers, but still you would be surprised that we lack such centers. And as per studies which I was going through, it takes almost 45 days from persons who have been operated and surgery has been done in other hospitals to reach a good spinal unit or care where these can be taken care of. So imagine that gap is still there. I have seen in even Indian Spinal Injury Center people coming after 6 months or a year of their injury and they are still not rehabilitated. They were just operated and sent back home rather. So it's a very major issue. You can't think on the Western airlines where, as Dr. Wadhwa said, their competition in taking for the emergency from the site of injury to the hospitals. Here, by the time they're, especially you see, it's a challenge in remote areas and hilly areas. The person to reach a primary health center is a problem rather. So we have to have policies which are suitable to our system. Yes, we can take a clue from the protocols which they have prepared, but they need to be adapted to our requirements or the people according to our environment and everything rather.
Thank you, Shivjeet ji. Very pertinent points. In fact, in the study that we did, more than 25% of the patients reached us more than 1 month after the injury. So you have brought that point out very pertinently. Yeah, Dr. Wadhwa.
Just a small point. I think there are 3 A's which are very important while we are discussing and trying to address this question. And I put it like this, that according to the Darwin's theory of evolution, it is not the fastest animal which is most successful. It is not the strongest animal which is most successful. It is that animal which is adaptable, which is most successful. So we have to adapt whatever best models that we come across from the Western world or from the Far Eastern world. The second A is assiduousness. That means we should be willing to work very hard, extra hard for our kind of patients. It cannot be that we have assessed, we have done the MRI scan and then written down the prescription or program and the things are done. The persons with spinal cord injuries, their needs are different. They are over a long-term basis. It is a continuum of care. So we have to work extra hard. They are not like persons with ordinary fractures or even transplantation of different organs, etc. And the third A is affection. We have to be very affectionate and sensitive towards the needs of persons with spinal cord injuries. I am not trying to say this in a very patronizing way. We have to allow them enough autonomy and independence, but we have to be concerned and sensitive to their needs and requirements and their rights. Thank you.
Thank you, Dr. Wadhwa. Very important to empower the spinal cord injured, as you mentioned. Dr. Narkeesh, do you have any quick points to add?
Yes, sir. I'm briefing only 3 words.
Thank
We have to work at the basic data, what Wadhwa sir has said. The physical, mental, as well as social data, that means ICFF classification, data we required in India first, so that we can know the reality in the ground level. So that we start the data based on tailor-based Indian situation. We modified the international policies. We can kept it as a high margin, but we have to work our tailor-based in Indian system, low economic country. So that's one support I need to be briefly this one.
Thank you, Dr. Narkeesh. Very important points again. So, point very well put across, that we have to assess the needs of the area, the resources of the area, look at the weak links. So you do a SWOT analysis, and then you individualize the approach with some standardization. So as very rightly mentioned, you could gain from the experience of the other developed countries, but you need to adapt it to local requirements, and only then will strategies be successful. So very important point put across, and we need to look this. For example, if we need to look into prevention strategies, so can we just adapt those in developed countries, or can we just adopt those of the developed countries to Indian requirements? No, because there are differences in prioritization. There are epidemiological differences. Fall from height may be the main cause of injury in our country. There is a difference in population distribution. Up to 75% of our population is rural based. There is differences in available resources, and there are differences in the mindset of the population. So you need to individualize and customize the strategies for Indian requirements. Now, coming to the next question. Would focus on low-cost, high-impact practices be a solution for underserved areas? If yes, please illustrate with some examples. So let me pose this question to my colleague and friend, Dr. Henry Prakash.
Good evening, everybody. Hope you can hear me well.
Yeah, can hear you loud and clear, Dr.
So, the questions is very pertinent to CMC Vellore, because CMC Vellore is a small town and it is surrounded by rural, and we have a very good follow-up in this area. We follow up spinal injury patients for about 100-kilometer radius, and most of the 100-kilometer radius is rural. And being rural, again, it has its own charm and it has its own challenges also. So because of our close follow-up, we have been able to actually look at our follow-up patients very closely. In fact, we published data from this 100-kilometer radius patients, and we followed them up for about 15 years, and we looked at the longevity. People with both tetraplegia and paraplegia, and to our surprise, if you follow them up well, handhold them, educate them, rehabilitate them well, at a very low cost setup, the 5-year survival rate was almost 86%, and the 25-year survival rate was almost 57%. So and the 10-year survival was about 76. So I think this data is quite comparable to data from the West. And we have not had any technology based or any expensive method of rehabilitation or treatment. We follow very logical and rational processes. For example, if I want to tell you, pressure sores, we manage it with plain simple saline dressing, and we believe saline works the best. Take off the pressure and the pressure sore heals. We are able to continue prone rehab on prone trolleys, which the patient, so that way the patient is not immobilized in bed. They are prone in that trolley and they go for therapy and they do their upper limb strengthening exercises. And we have some advice on protein, which is available here locally, like seeds and nuts, to better their protein and hemoglobin. So with these kind of low cost, high impact, our results have been very good. And if I can tell you, as of now, with all the inflation and the tariff changes, a patient in the general ward, when he comes in, he spends about 45 to 50,000 rupees per month, inclusive of everything. That is therapy, bed charge, nursing charge, professional charge, which I think is quite manageable by most of our patients. In case we need to do a surgery on him for the pressure sore for a small flap, again, our rates for these patients are very low. About 35,000 for a flap surgery, including anesthesia and theatre charge, is what we charge for, especially for the spinal injury patients here. So I think the magic here is networking. Now that internet is there, hand-holding is much more easier. With telemedicine, we are able to hand-hold them before they even come to us, advise them on bladder, the catheter, the prone lying, the food, nutrition. And we have a social work team, which is very good, which we can, they can reach out to them, see them, meet them, make a plan, even before they reach the hospital. So I believe that networking now is quite easy. Video conferencing is quite easy. People, all of them are quite literate with technology, and we can reach much more further at a much lower cost. And of course, the rehabilitation protocols also follow a lot of hands-on therapy rather than machine-based. So that again keeps the cost low. And of course, wheelchair calipers, we are able to help as many patients as possible without much expense. So I think these are the examples. There are a lot more which I can talk about, but these are the ways we are able to keep the cost low and the impact high. Over to you, sir.
So thank you, Dr. Henry. So this also reinforces the first point that we need to customize practices of the West to local requirements. And that's a very pertinent point. And I think the model is very much required across India, such that we can adapt it to Indian requirements. May I request our other colleagues and friends who are there, who have joined us, if they have any comment, any suggestion, any question, please use the chat box and type it out there. We'll try to come back to you subsequently, or at least let people know about the relevant points here. Again, the lived experience from a very dynamic person who has been greatly involved in advocacy in this regard, hence the views would be very important. My colleague and friend, Dr. Ketna Mehta, please.
Thank you, Dr. Chhabra. Everyone, please call me Ketna. I am a mentee for life. I learned from all of you. Congratulations, Dr. Chhabra, for this wonderful NGO. And I loved your logo. It's all about positive growth. To mention a little bit about Nina Foundation, we are a very small NGO, 20 years old. We do not have a rehab center. There's no center. But I think when they say that when you are under challenges, you know, we innovate and we come out with things. So what we have is a wonderful team. And yes, we work hard and we try to come out with solutions. I really like the question that you have asked about low cost, high impact, because that's exactly what Nina Foundation does. So I'll give you directly two examples. We have seen I think India will be the only country where people die because of bed sores. And it really makes our heart cry when we see a person, even a paraplegic, dying. So what, and this pandemic has actually worked out like a blessing, because even though we don't have an institution, we used to have, camps, etc., with a multidisciplinary team. We have an OPD weekly in Mumbai. Or a quadriplegic who is in a village and lying down, and there is no communication after the patient comes home. That has been our biggest. In fact, that is one of the biggest problems. And if somewhere we can fix it in terms of the community of spine surgeons, orthopedic surgeons, and the bigger thing, because there is no communication in terms of what is supposed to be done. So with lack of information, especially quadriplegics land up with use. So what we do is, this is a specific example, our team has a hope kit for bed sores. And the gauze, the cotton, the Gemji, the hydrogel, the Mega Heal, the saline, the spirit, the Lizol, everything is put together. And by video call, the photographs and the videos of the bed sores, grade 2 and grade 3. Imagine how much this hope kit costs. We are not talking about the knowledge, the communication, the guidance, everything. But for 2 months, it is less than 600 rupees, because all this is created and it is sent. And as soon as the skin becomes pink, it is such a big satisfaction. So that is about bed sores. The other example I would like to mention is about online physiotherapy. We use a broad word, rehabilitation. Let me tell you, and Dr. Chabra knows about it, my friends know about this, that in Mumbai, okay, the financial capital, I had a home-based rehab. So I have been through this journey of having only a physiotherapist and my family, fortunately with doctors, where we learn activities of daily living. So this is the case in most of India. Most of India, this is the case. And we had this young 16-year-old girl met with a road traffic accident, the trauma of losing the father, sole earning member, and they had to move from, because the father was working in a government place, they had to move to their uncle's place. 1 room and 8 people living in that house. She's on that bed, and we calculated. Luckily, Amazon was delivering during the pandemic, and the first thing we gifted her was a smartphone, because she needed to talk to us and we needed to motivate her in terms of all this. So our entire team communicated with her, communicated with the uncle, because I think the family plays such a big role. She was lying in diapers, etc. 1 walker, physiotherapy equipment, complete knowledge, communication free of cost, 666 rupees per day. And we have that calculation, low cost, high impact. Today, it gives me goosebumps to communicate to you that she stands on the walker without any help, and she does that for 1 hour. Thank you.
Oh, that's great, Dr. Ketna or Ketna. A wonderful viewpoint, and I think we need to take carry home points from here, and in order to move forward. Dr. Bala, do you have any quick points to add on what has been discussed?
Yes, sir. Just a very, very quick. When I initially wanted to start a rehabilitation center, and I went and approached the corporate hospital where I was working. The hospital obviously had thought about it, but they thought that it is not going to be viable. And as Dr. Henry Prakash said, an institution like CMC can do wonders because they are very large. They are been there for more than nearly, I think, about 100 years. But a corporate hospital in an urban city cannot provide the same kind of challenging health care. And that is probably one of the reasons where a lot of metros do not have a large rehabilitation center. So my point was really that when I went up and they said no, and we thought that what is the solution? And so we approached NGO like Rotary. So Rotary, who are well known as an NGO to most of us, are able to provide and pull in that money from various sources, national and international. So we thought that we can provide the least possible with the minimum amount of physiotherapists, what we can do with vocational training. So we actually gave in for about 50,000 rupees, 3 months of rehabilitation, along with vocational training, with just 3 physiotherapists, and we treated nearly 60 patients over a period of 2 years. And this created a huge impact on these people who really wouldn't have had an opportunity to rehab. In fact, we got an award from our late Abdul Kalam for this as one of the best projects that he had observed. So these kind of small changes is what India needs. But when I came to Chennai and when I started my rehab center, people still in Chennai want robotics, they want various other things because the information that they are given is probably not right. So I think still for a country like India, a low impact, low cost, high impact rehabilitation would definitely, make a big revolution in how we do. And I think it's just one example I want to say. It's still possible to do, excellent rehab at low cost.
Thank you, Dr. Bala. Very pertinent point. I think we have plenty of evidence like the Patna model where they train the attendants of the patients to take care both in the hospital and also at home. And then you have the barefoot doctors. We know that in our country, strong family, spouse and community support and availability of cheap as well as abundant manpower are the main strengths to overcome the challenges of SCI and other spine issues. And these all can lead to low cost, high impact practices like involving the family and the community in empowering persons with spinal cord injuries. Similarly, from Africa, there are examples of how pre-hospital trauma care can be provided within the available resources using low-cost measures but high impact, which have a high impact. And they train people in this regard with a great efficacy. So coming to the next question, is it important to develop and follow local clinical guidelines and protocols? Please drive home the point with an example. And here I would want to put this question across to my, colleague and a good friend, Dr. Balamurli.
Hello, sir. Yes. So as Dr. Sanjay Wadhwa first mentioned that, we cannot bring in international guidelines and insert it into a Southeast Asian country like us. Because I trained in London and all over Europe and the US for about 16 years. I worked in 3 of the rehab centers, including Stoke Mandeville. When I returned back to India, probably 90% of what I saw there, I don't think I could have implemented in India. From the pre-hospital care to post-operative care to the rehab care, because the funding is very different. So we cannot replicate that care. And we've seen enough examples in our group already. So I would just divide this that, we are fragmented in many ways. We are fragmented at the level of doctors, with spine surgeons, rehab specialists. Then we are fragmented among consumers, their expectations. We are fragmented among the scientists and researchers. So, each people have different views about how to manage a spinal cord injury. And all 3 of them do not communicate in all forums. So doctors know what they need to do and they have protocols. So I would say if you take a surgeon, they're probably well trained because they know exactly what kind of a fracture, what to do. Whereas a rehab physician knows exactly what protocols would work for it. But are we actually meeting the end point, which is the consumer? So their expectations are totally different and it varies from urban to rural and from location to location, their local adaptability. And scientists who want to find new products, bring in new things. Again, they are not connected. So I think that is where we really need to work on in our country, because this exists abroad, where all these three people get together and have multiple meetings. And I hope that this forum will make this as one of their initiatives, is to bring all these people together and where we can all decide for the end user. So I think we do not have, I would say we do not have systematic policies in the management of spinal cord injuries in our country. It is regional, probably the south, north, west, east. There are good pockets of protocols followed. The pre-hospital policy should come from the government, because majority of trauma is picked up by the government. So we need to actually go to the government about how we deal with policies and protocols pre-hospital. In hospital, we have a control, but the problem is we do not have data. We don't know where which patient goes. If you take a city like Mumbai, there are probably, about 200, 300 surgeons who operate on the spine. And I don't think there's any data either in Chennai or Delhi. We do not have data. Unless we have data, they're not going to go to a rehab center. And we do not have sufficient centers. So I think my conclusion, really, I'll keep it short, is that we do not have proper guidelines, but we do require guidelines. And we have to work. And over the last 6 years I've been in India, I've been seeing Dr. Chabra developing so many guidelines in our ECCON meetings and presenting them. But I think that has to be implemented national-wide. So, just in one meeting, in small groups, it does not work. It has to be implemented nationwide. I really don't know the answer how that's going to work. But I think that's where we need to focus. Thank you.
Yeah, very pertinent point again, Dr. Balamurli. For the Indian Orthopedic Association, I had compiled a white paper on spinal cord injury management with where we got inputs from more than 400 experts. But thing is, these guidelines need to see the light of the day, and we need to update them to current requirements and have them come to a consensus and have them implemented. So very important point that you have raised. Though there is, we need to follow local clinical guidelines and protocols, but where are they? We need to popularize the local guidelines. So here I would request again to have the lived experience from one of my another very dear colleagues, as I talked about, Dr. Komal Kamra.
I think so far people have been talking about local as in India. I would think even local as in within India. India is fractured into lots and lots and lots of customs and traditions and eating habits, for example. You said example, so I'll just give one example. Now, if a person reaches a rehab center and does not get the food that they are supposed to be normally eating, they do not perform well, as they are not up to the mark when they go to a rehab center. And then as it is, you have bladder and bowel issues. So it has to be not just local as in India, but it will have to come down to even local as in Northeast, Southwest, and even amongst them furthermore. So if I bring a South Indian to Indian Spinal Injury Center and feed him roti, one nahi karega. He or she will not be able to perform. So that is where I would want to, how do we tackle that issue? That hasn't come up so far. We've gone from international to national, but within the nation, the diversity that we have needs also to be catered for. Thank you, sir.
Komal, very important point that you have brought out. Local means local. For example, if you rehabilitate a person from a rural background in an urban setup, when the person goes back home, it will be utter disaster because you have not rehabilitated to the rural requirement. So that point is also very, very interestingly and very rightly put forward. Dr. Henry Prakash, do you have anything to add to what has been discussed pertaining to this question?
Yeah, so the question was clinical guidelines. Right. So I think clinical guidelines, again, we just cannot follow what the West does. For example, they would anticoagulate everybody soon after injury or put them on Clexane. We cannot afford that. We can't do that. So we need to have our own guidelines, and many of the complications which SCI people face. I think one easy way of doing to have a proper syllabus or a curriculum to all the teaching institutions. Now, most of the medical colleges do have a department. So if we have a strong syllabus and we teach the postgraduates the proper clinical work, and then probably the clinical guideline setting up will be much more easier. Like ISCOS has done a lot of work which people can read up, students can read up like that, probably like what you have done, sir, already generating evidence and generating it for our sake and forming protocols will be good.
Thank you, Dr. Henry. One example would be that strong religious beliefs and facets like doctrine of karma help spinal cord injury and family members cope with the disability and face the challenge successfully. So this is what is as per local requirements. So there are numerous examples where they have provided evidence-based, integrated, sustainable and scalable spine care programs as per local requirements. And this initiative, they have compiled resources to implement a spine care program in communities with limited resources. So there are examples which are available, but point very well put forward that we need to also not only develop local clinical guidelines and protocols, but also popularize them. So coming to the next question, what is the importance of dedicated research to improve access and quality of spinal injury care in underserved areas? And here I would want to request Dr. Narkeesh to give his viewpoint.
Yes, sir. So the research is I'm working last 50-20 years in SCI. So there's a research in India. It's the biggest challenge because of we are not getting funding properly. So I suggest to you, sir, please give a guidelines to SERB, Science Engineering Research Board, Department of Science and Technology, and ICMR. So we should them to develop a good researchers. When it is get a funding, then only we can develop the data very well. And across few articles I crossed. So one article 2018 you did from the spinal cord injury with a very good research come out the pre-hospital, hospital, and post-hospital, the difficulties in the patient as well as sexual fertility. These are the big issues. It's only come up in 2018 with your team. So what I want to say is the research should be throughout India. It needed to be a multi-center work we needed. And another one is journal you mentioned in 2021, International Journal of Orthopedic Sciences. They did a good study and put it together. They said rural spine surgery and challenges. Yes, sir, this is really the article is very well is mentioned. Only the surgery they do, rehabilitation is missing. And same I'm accepting. The most of the rehabilitation is cheaper, but the residential and food is becoming very costly in the institutional base. Either we have this one Indian system and the nearest Gurudwara and social service center can tie up for the minimum requirement of stay and food and work very well. And as well as there is a Journal of International Research in 2020. They said the research implication of patient with SC is very limited. So a lot of research is coming up. Like I'm doing with the RTMS, I'm doing with surface spinal. But the RCT's level and the publication in India level is very low. So I request everyone, it should be need a guideline so that whether it is effective or non-effective, we should apply with the upgraded method so we can get a better result, sir.
Thank you, Dr. Narkeesh. Dr. Komal, what would your viewpoint be with regard to this, what has been already very rightly highlighted by Dr. Narkeesh? Komal? Komal, you are muted.
Yeah, I'm audible now?
Yeah.
Okay. What I would look at research is not what actually would cater for. Once again, I'll come down to local means local. So we have talked about aids and appliances, types of beds and mattresses, critically the home care, etc. there are so many alternatives that I've come across, which people in my years of peer counseling have come across and told me. I mean, just imagine in the Northeast, they make wheelchairs out of bamboo. And they have used in the South, I'm sure Dr. Henry Prakash would be able to tell, that shavings of coconut nuts being put into beds, bed mattresses. So such things also need to be a part of our research process.
Thank you, Komal. Important to develop locally, use local resources for research to come out with innovative strategies. That is a very important point. Dr. Wadhwa, do you have anything to add to what has been mentioned with regard to the question of the importance of dedicated research to rise up to the challenge?
No, I essentially agree with what has been expressed by the experts. It is a myth that research means investment of a lot of money or imported equipments from abroad. It is a myth. There is a lot of quality research which is possible, provided you have identified the problem area properly. You have made a good plan how to answer the question that is in front of you, and you are more focused. Many a times there are research projects or activities which are started with a lot of enthusiasm, and then midway the enthusiasm dies down, or you get tempted and attracted to another area of research without completing the earlier research that you have started. And lastly, my experience has been that it is the institutions which should play a more active role in doing the research. Every postgraduate student, whether in physical medicine and rehabilitation, orthopedics, or other disciplines, including post-graduation in the therapy-related courses, they have to do a dissertation or a thesis work. And many a time it is more or less a duplication of the work already done, because it is easy. So identification of the problem area is very important, and we should be willing to work hard. Then only some meaningful research will be done. Otherwise, the same thing which has been done abroad, you pick up that article or 5 similar articles, and only in Indian subset of population you do similar things. And then at the end, I get many theses for review before the candidate is declared successful for final exam. And the conclusion in 7 out of 10 theses is that no final conclusion is possible because the sample size was small, the follow-up was short. So this is the persistent paragraph in most of the thesis. Then what is the point of having a research spread over 2 years when the sample size is small and the follow-up is short? We should have something like a relay race in the research area, that a part of the research has been completed by the first runner. It is very focused and hard work is done, and he passes on the baton to the next researcher on the same area of research and takes it forward, so that by the time the fourth runner has run his part of the race, we will have a sufficiently large sample and adequate follow-up, and the research will be worthwhile and meaningful, which we can proudly showcase in front of the international audience also, and bring about a policy change.
Thank you, Dr. Wadhwa. Very important points highlighted by you. So, as Dr. Narkeesh said, we need to have funding also available, and there is evidence that research endeavors can have a major impact on spine care programs. With cooperation and funding, it is possible to conduct the research necessary to provide sustainable spine care programs that have the potential to improve the public's health and quality of life. For example, very rightly mentioned also by Komal, that challenges stimulates health professionals and spinal cord injured as well as caregivers to come out with innovative ideas. And examples are reusable catheters, use of cotton cloth bag for storing catheters, the floor mobility device, the use of honey and vinegar for pressure sore dressing, And there's also a traditional Chinese herbal formula which is used for pressure ulcers. Ketna was also talking about what they use for pressure ulcers. So research needs to come out so that we can come out with low-cost, high-impact practices which can serve the needs of the local population. So my next question would be, how can targeted education, professional retraining, and professional oversight help to rise up to the challenge posed by spinal cord injured in underserved areas? And let me ask my colleague and friend, Dr. Henry Prakash, to throw light on this point.
Again, I think professional retraining, when it comes to focus on spinal cord injury, I have seen a lot of colleges where therapists are graduating from who have hardly seen spinal cord injury patient being trained. So they do read up, they have some theory, but then it's not very spinal cord injury specific. So I go back to the syllabus. If we can build up a syllabus, both for the occupational therapies, for physiotherapy, physical medicine, where we can have a separate focus on how to manage spinal cord injury patients, the complications with locally available evidence and locally available infrastructure, I think that would be great, because at least they learn the theory part. And later, probably we can have professional retraining with not all colleges or hospitals can train, because they might not have enough clinical material. But of course, things like observerships, coming and seeing what is going on in a spinal cord, well set up spinal cord injury rehabilitation center from colleges. They can come spend a day, look at what is available. And the third thing is maybe a peer group talking to students and trainees as to what their problems are, what the difficulties are, will be the real way of teaching. I can always teach something to my student on the wheelchair, but if a peer person, a spinal injury person tells them how they go through the problems and what they do to circumvent it, there's nothing like that. I can only teach theory, but a spinal cord injury patient can come and teach the whole textbook in a couple of minutes with some examples. So that's a way forward.
Yeah, very rightly mentioned. One, we need to ensure that spinal cord injury management is included in the curriculum of all healthcare professionals, and also that we need to make use of the lived experience. The peer counselors can counsel far better when it comes to simple tips of management. So may I ask Shivjeet ji to dwell further on this issue? Shivjeet ji.
Thank you, Dr. Sharma. You see, I do agree. We have talked about we can put this in the syllabus of therapists and others. But you see, without retraining them, I'll give you an example. In ISIC, when these new ward boys join, because they are in contact and they keep on changing. So first 2 days, they are being taught by the older ward boys who are there, senior ones who are there from last 3-4 years. They train them how to lift the patient, how to shift them. And same way in the physiotherapy rehab center department, the seniors tell the newly joined people how to go about taking care of the patients in the therapy and other areas rather. So retraining is really, really very important. And you see, problem is that we have n number of spine surgeons and orthopedic surgeons, and you can count the physiatrists on fingers in the whole India rather. This is a gap rather. You see, rehabilitation is more important as far as a spinal cord injury at this point of tomorrow. When researchers come and people start walking is a different issue. But you see, we have to revisit this whole curriculum of studies and in medical colleges. We have rehab centers in very few number. Why can't we have in medical colleges proper rehab centers. And you see, focus of most of the rehab centers which I have come across is medical rehab. The social model is not there in most of the places, rather. We just try to make them independent physically. And that is what we try in most of the rehab centers. We do not prepare them from the point. So it is very important that training and retraining is of various professionals involved in that. And no doubt, you see, long back when I had joined ISIC, there was an Inspire project, which I was there for 3 years. And I had gone to Calcutta, and so nobody knew what a peer counselor is. One of the doctors, imagine, he questioned me, why can't a doctor be a peer counselor? I said, you'll have to come to the wheelchair after a spinal cord injury to be a peer counselor. So what I mean to say is, and you see, if we employ people with spinal cord injuries as peer counselor in different institutions, even it could be a good employment for them. And as Dr. Henry mentioned, they can. I had gone to Miami for a CME program, and I saw a occupation therapist, a wheelchair user occupation therapist, a spinal cord injured person as occupation therapist. So that is what is needed for better sensitization and better results, rather. So I believe targeted education and retraining can do wonders. And you see the goal plannings. I have seen that though they involve the individual spinal cord injury, but people hardly hear to them. They hardly ask them what they want. They start simply telling them, this has been done, your balance is being done, and this. They don't ask him what you want to do or help him to find a goal, rather. It may be that the person is not in. So these things, the professionals need to have little more oversight and insight into things so that they can do a lot better job than what they are doing at this point of time.
Thank you, Shivjeet ji. Very important points brought out by you. Dr. Bala, do you have anything to add to what has been discussed?
I think everything has been discussed, but one thing I just wanted to mention in terms of medical professionals. When I started off a rehab center in Chennai with now we have currently around 40 beds. I thought that, everybody in the city would be referring patients to me, and there's no rehab center here. And there are at least, 100 spine surgeons, orthopedic neurosurgeons. But most of them don't even tell their patients that, go look out for a rehab center. So I think the awareness should start really primarily from doctors. Re-educating them the importance, to insist that, rehabilitation is the only way that this person who's an paraplegic or quadriplegic is going to have a real life. So I think, our education and re-education should start with awareness, whether it starts from medical college or post-graduation and all the other problems we discussed. It has to start right from really basic. From a general practitioner should know where to send them.
Yeah, thank you, Dr. Bala. So we talked about education and training, and in this model, as we talked about before, by combining local input and evidence-based sources, models of training were devised to improve pre-hospital trauma care rendered to roadway casualties in low-income countries. This was the model from Africa. So we can develop it. Similarly, the organizations have been doing it in various countries, and there is experience that education can definitely help in this regard also in developed countries. And WHO also says that there should be professional oversight into this, whatever education is done, so that things are moving in the proper direction. Coming to the next question, what role can policymakers in underserved areas play to overcome the challenges posed by spinal cord injury? Dr. Sanjay Wadhwa.
Thank you. But before I try to answer this question, I have noticed that Vijay Gardeshji has raised his hand.
Sure.
So my request, if you allow him to say what he wants.
Definitely.
Then I'll come back to answer.
Yeah, sorry.
Thank you.
Dr. Chhabra, I am an engineer I am not a doctor. I am an engineer doctor, you can say, because I did a PhD in power systems. Anyway, I had a spinal injury in 1977 March.
Right.
And since then, I have been in a wheelchair. I did rehabilitation. I was rehabilitated under Dr. Walsh, who was director of Stoke Mandeville and then later on private practice in England. And later on, I have come back to India and worked with Bharat Heavy Electricals, which was my parent company. I fully endorse a lot of points. For instance, you must ask the user, that is the wheelchair person itself, what are the requirements or what are the difficulties felt. In England, I had found that the physiotherapists and the young doctors during their medical education were asked to sit in a wheelchair for 2 days, tied to a wheelchair, and then made to move in the hospital or wherever they were. And then they later on came to know that what it is to climb a step or come down a couple of steps, or height of the mirror near the wash basin, and so many other small points like that. So that is one very important point of sensitization. The other point is that there are a number of difficulties which can be a separate topic for your discussion. But coming to research in developing some calipers, we had, I was associated with the Regional Research Lab, and they had developed a very light caliper. In fact, the weight of the caliper which I had from England was almost twice. They had done it out of some fiber material which was being developed by us for gear casing of traction motors in electrical locomotives. But that could be used, and that was what I had, those calipers. So I found that materials and mobility, these are quite important aspects. And there are a number of things to talk about, but this is a medical forum. I am just a patient, or after that, I worked for almost last 40 years, you can say, or 30 years. Last 10 years, I'm not working. But various types of experiences, problems, and difficulties. In fact, sensitization is a very important aspect in Indian culture, Indian situation. For instance, when I came to Delhi, I had to first convince that my mental faculties are not changed, they are the same. And it took some time to instill that kind of a confidence amongst my colleagues in meetings I went and various forums. But it was ultimately, it was all well, no problem. About physiotherapy care, my wife had trained herself to do minimum basic exercises for me at home, and active and passive exercises we used to do at home ourselves for all these years. It's only last few years that I had a physiotherapist, but otherwise I have generally been keeping fit. I'll be 85 next month, and generally still keeping fit. Still, I don't work now with that kind of a working schedule earlier. But these are some points I felt I just interjected in the doctors' forum. Sorry for that.
No, Vijayji, this is not a medical forum. You see, it is a community forum, because we are looking at real life scenarios and the challenges and how to overcome them. And that's why parallelly we are taking the lived experience. So thanks for contributing, and your points of sensitization are very important. We apologize, we do not have as much time, but we will have this as we will have such meetings at least twice in a month, so there will be plenty of opportunities to discuss in this regard. Dr. Sanjay Wadhwa?
Yeah, thank you. First of all, I want to endorse what Shivjeet said just now. And I entirely agree with his point of view that people need comprehensive rehabilitation services, including medical, but other components of rehabilitation also. Now coming back to answer my question regarding the policymakers and their sensitization and the role they can play. So in India, we have a very strange system which is different from the Western world. The highest body to make policy in India is the Parliament of India. It has its members, and then there are certain standing committees, and depending upon the topics, there are certain select committees which pick up certain areas of importance and develop policies and all. Then just below that, we have the Niti Aayog, which is for policy making at present. It has member experts related to various areas, including health, agriculture, economy, industry, etc. Then there are certain key officers in various ministries which have stakes in different conditions. For example, in the case of spinal cord injuries, the stakeholder ministries will be more than 2. Health and family welfare, obviously. So the secretary level people or additional secretaries in the Ministry of Health will be involved in policy making. People from the social justice and empowerment will be there. Road and surface transport will be there. All these things will play a very important role, the bureaucrats basically. Then there are indirect contributors also, which are known as officially as the think tank on various areas. And one important think tank in India in the health sector is Public Health Foundation of India. They influence the policy making as far as the healthcare sector is concerned to a significant extent, whether it is cardiovascular disease or stroke, etc. They have been involved in framing the national level programs also for these things. Then there are other industry associations also like ASSOCHAM, FICCI, CII, NASSCOM, etc., which are involved in policy making for various issues and aspects. Then very eminent medical men of the country, I can name some of them like Dr. Naresh Trehan, Devi Shetty. And I wish there is somebody who is lobbying for persons with spinal cord injury also of that stature. That will influence the policy makers more easily and quickly. But efforts have to be sustained and continued. I am not losing hope. But it is important to remember, I was reading a book and a quote from the former governor of Reserve Bank of India. And he had a different take on the policy makers. And there is no offense meant to policy makers, but looking at the state of affairs in India after 75 years of independence, he remarked that you are going 60 miles per hour or 70 miles per hour with rain pattering on your windshield. And the windshield is fogging up. And you are on a highway. So you can't stop also because you could cause a pile up. But you have no idea what is in front of you or where you are going. This is what he has reflected about the state of affair of policy making in India. We make wonderful documents, but the implementation on the ground is what is lacking severely in most of the areas, whether it is industrial production, whether it is employment generation, poverty alleviation, etc. And the same applies for spinal cord injury related policy making also. So I feel that there is an urgent need to sensitize the policy makers that I have just now mentioned. This is from a standard World Bank document related to India. But overall, in the present scenario for the last many years, in successive governments, the policy makers have become risk averse. They don't want to come up with some ideas. Later on, if they backfire, they will be held accountable. There have been several instances when very capable officers started certain programs and due to reasons other than their competence, they did not meet with that much of success. So people have become risk averse, or what used to be labeled in the previous government as policy paralysis. This is also a reality of our country. There was a stage when there was policy paralysis. Then there is a stage where people are afraid of speaking their mind up now. There is only one office which controls everything and decides policies from Ministry A to Ministry Z. So if you can have a word with them and they accept your idea, then the policy will come or it will be changed the way you want it. Otherwise, you keep banging your head against a wall, nothing will move. And finally, I want to say that unless there is a realization of the need for policy in this particular area of spinal cord injury care and management from the top, so that the legislatures feel motivated to adopt this particular area in their respective constituencies. For example, if an MLA or an MP ensures that his village or district or constituency will have improved care for spinal cord injury persons within the next 5 years, there is no reason why the scenario will not change in the state or across the country. Thank you.
Thank you for raising very important points. In fact, our next question is pertaining to this only, what has raised, what is the answer to this. But before that, I will request Shivjeet ji to give his views on this. Shivjeet ji, you are muted. You're muted.
Yeah, sorry. You see, I have one thing to say. You also mentioned that what Victor Hugo Long said, nothing for us without us. Now, you see, we hardly involve people with spinal cord injuries when we are making policies for spinal cord injuries. It has started in a small way, but still, I believe the policymakers need to involve persons with spinal cord injuries. And you see, if I'll give you an example. If you talk of Department of Empowerment, and which is now separated from the, it's a separate department altogether. How many people with the disabilities are there as part of that department? You see, there are different, even persons with spinal cord injuries working in the government at secretary and director and other levels. Why can't they be posted to those departments for maybe on deputation or things? At least in such a department can have such wonderful policies if people with spinal cord injuries or other disabilities are part of the decision making. Rather, there are certain bodies which are being made, but you see, it is just for namesake. There are people there on that one, or they say 5%, one person with the physical disability, one with the blind, and that way. I believe more and more representation of people with spinal cord injuries has to be there for right perspective of policy making. Rather, that is very, very important, and I feel and it needs a push. Rather, as Dr. Wadhwa said, this policy making, because without policies, government policies, the masses can't be taken care of. Few people who have money, they can take care of themselves. But if we are talking about underserved people, it has to be government policies. It has to change and proper. And other thing is of implementation. Even the implementation agency should have more and more people with disabilities. Then only, because they know, the wearer knows where the shoe pinches, and they will definitely work towards implementation if they are there in part of the policy making and implementing policies. Thank you.
Thank you, Shivjeet ji. Dr. Henry, do you have anything to add to what has been discussed?
No, I think it's been said perfectly well. Till they are there, nothing will move so easily.
Right. So now, when it comes to policymakers, you know, they can play a very important role, but how to get them to playing that role is what is being discussed. So we know, for example, that primary prevention is very cost effective, and legislation and enforcement needs to be brought in this regard. But if we need to look into solutions, there are solutions. For example, if in India for spinal cord injury, we have a network of spinal cord injury centers with a pyramidal organization, we can meet the needs, the requirements of the country. But how do we do it within the available resources? Resources don't need to be large, right? If a small spinal cord injury unit can be made in all medical colleges and hospitals having a department of PMR in India, I think we'll go a long way in meeting the requirements. And spinal cord injury management doesn't require sophisticated equipment. It just needs trained manpower, and they can be trained easily. So we are running out of time, but I'll quickly come to the last question. How important is advocacy and public support? Can it impact policies? This was what Dr. Wadhwa was referring to. How can we impact policies? How can we get them to make policies? And can advocacy and public support have an influence in this regard? Can I request Dr. Balamurli to respond to this?
Yes, sir. Thank you. So as Dr. Wadhwa had said, that policymakers are either the government, think tanks, influencers, individuals. There are so many people who could actually influence. And there's a saying in Tamil Nadu, that the closer you are to the policymaker, the policy can be happen. So we are very, very far away in Chennai from the policymakers. So I thought, actually, what can we do? And I had an opportunity, and I just really want to share this very important thing, which is going to really impact our whole country. I had an opportunity to meet the Star Health insurance owner, the MD of Star Health. He's based in Chennai. So I was treating a relative of his, and so he told me that he's the MD of Star Health, and so immediately I contacted him, and this was during COVID, about a year ago. And I told him that, see, you are one of the leading insurance companies in the country, and you control finances of many people's life, and you don't have a policy for spine injury, brain injury, stroke. So he was very interested. He's a doctor, he's a surgeon, he's a general surgeon trained from UK. And so he said, let's meet over coffee. So we had a cup of coffee. This was about almost a year ago. And I told him, we have a center in Chennai called Hamsa. It's a small rehab center. Why don't you visit? So he actually made an effort. He came during COVID. He spent a whole day there, and he said that I'm really impressed and I wondered why I cannot. So he immediately wrote to the financial authorities of India. In 3 months, he had a go-ahead from the government. So we set up a team of doctors. We set up a team of financial people. We worked on our entire policy. We wrote to them, we worked out, calculated the finances. And actually, I'm happy to say that this week or last week, for the first time, Star Health is announcing a package for spinal cord injury, brain injury, and for stroke, and for pain management. So I think this is going to be a huge revolutionary change, because if one Star Health gets, I'm sure every other insurance company is going to follow the bandwagon. So I think, all it happened was me persistently knocking his door for a year. I pulled him in, I pulled his team, the entire team, we brought them to Hamsa. We said that, without this, people who can, even the middle income, the upper middle income, they cannot afford, long insurance. So I think, influencers are there everywhere. And it's going to be announced very shortly in a press release, I think this week or next week. And this will impact many people. So I think, from the grassroots at every level, there are people who can make an impact. And I just wanted to give you this example. So thank you. I just wanted to share this.
Thank you, Dr. Bala, and compliments and congratulations for this great initiative. In fact, congratulations due to all of us, because this is a great milestone, and this may be a landmark milestone in the history of management of persons with disabilities. So compliments in this regard.
So, and I also wanted to add that every hospital who's empaneled for Star Health can immediately write to them, and you're straight away empaneled.
Oh, great. I will change the order a bit. I will request Dr. Narkeesh to give his viewpoints here on this question. Dr. Narkeesh, are you there?
Yes, sir. Yes, I'm here, sir.
Yeah.
Sir, basically what Balamurli sir is exactly it's needed. For my side only one, sir. The paper will speak, people speak less. So we want to make many papers, many policies, many guidelines in the eyes of government. Then only this policy come up. If a SCA patient write his demand and work in the newspaper, it can be recorded. So I want to say we will in the different level from the consumer point of view. What are the needed? They should be come up with the paper. As a therapist, we work with the papers. As a surgeon, we need a papers, and we together we make a large, huge paperwork. Will speak in India better than the people of speaking of any individual. So we work more documented rather than working in the voices. So for me, we need more and more brainstorming, return material, which can change the policies, and it works definitely. Thank you, Balamurli sir. You did a great work. You need many steps to come up with this type of activity.
Thank you.
Thank you, Dr. Narkeesh. In fact, why I changed the order was just because such an important discussion needs to have the last viewpoint as the lived experience viewpoint. So that's why may I request Ketna ji to give her viewpoints on this important issue.
Thank you, Dr. Chhabra. At Meena Foundation, we've been doing a lot of advocacy efforts because having lived with spinal cord injury and having seen others with spinal cord injury, realize there are gaps so much. And my PhD was on this topic, and Dr. Chhabra knows all these gaps which have been created, and in this 26 years, I haven't seen the gaps reducing. So a long way to go. What are the advocacy campaigns that we have done? Prevention. So for prevention, we have done so many things. We've had rehab conferences, public forum, pledge of, I have been the editor, guest editor for Design for All, and given all kinds of innovative ideas in terms of car manufacturers, everything in terms of how we can prevent. Because there is no rehab, we need to stop this surge. Secondly, Dr. Chhabra had helped us with that. We ran a hope campaign where, we were the first ones to create awareness about spinal cord injury in 2009 with the Spinal Cord Injury Awareness Day, which we are in the 13th year. And at that time, we realized that it is so important to have a statistic, because our community is, all of us together need to have, and thanks to you, we have a number, 1.5 million people with spinal cord injuries in India. Whatever, now for 6 years, we have been saying this number, but we need to have that statistic. That campaign is there. Third is about, and Dr. Balamurli, we need you desperately now, because we have been running this campaign. If you read the Persons with Disability Act, there are 21 disabilities noted. I'm not happy to be clubbed under locomotor disability. I'm not happy to be clubbed under multiple disabilities. And we have been doing this since 2012. Written a letter to the Prime Minister. We got a reply back 3 times, ran a campaign, ran a communication. I think Dr. Chhabra, you are the face, like Dr. Devi Shetty, Dr. Trehan, for spinal cord injury. You're close to Delhi, and we need to have spinal cord injury as a distinct, separate disability. That happens, policy happens, all of us lead a better quality of life. Thank you.
Thank you, Ketna ji. I'll come to your point subsequently, but coming to how important is advocacy, public support, can it impact policies, right? Spine 20, you may know, is a global advocacy group which is promoting evidence-based spine care of value. And we just finished with that meeting just a week ago, and this advises the G20 countries, gives recommendations about local projects that implement value-based practices with healthcare policies that are culturally sensitive based on scientific activities. So if people can also, a G20 recognizes them. So if they can recognize them, why can't we get our government to recognize an advocacy group, right? And it is, there is good evidence that low public support for government interventions in health, environment, and other policy domains can be a barrier to implementation. Also, the public support for policies in a range of domains is sensitive to evidence of their effectiveness as well as their ineffectiveness. So you know about the Spinal Cord Injury Day initiative, Ketna ji also mentioned. This has had an impact. We've been writing to the Health Ministry several times, and it is for the first time this year that we have the Government of India, through the Directorate General of Health Services, Ministry of Health and Family Welfare, allowing the Injury Prevention Week to be held under their aegis from 1st to 7th September. So this is a big milestone, a big way forward, and we need to carry on, right? We don't need to lose hope. We need to carry on with our advocacy activities. So it is said that listening to an underserved population is how you begin to understand them and serve them better. This was repeatedly pointed out also during this discussion. And this is also because many of them form part of this panel discussion today. The personal satisfaction of doing good in the community and increasing value and holding true to the Hippocratic oath and being able to provide services to those that are in need is very strong moral reason to provide services for the underserved. It is in our hands to create a better world for all who live in it. Let's join hands to improve spinal injury care in underserved areas and to alleviate the burden of spinal injury. So, friends, we can't let a discussion on this very important topic just be left at this, right? We need to carry it forward. And during this discussion, when there were talks about this, I was just thinking, how can we carry this forward, right? And it occurred to me, if you all agree, we can publish a document on rising up to the challenge of spinal cord injuries in India. As I mentioned, I had come out with a white paper with a survey from many experts and also persons with spinal cord injury. We can compile another survey on how to rise up to the challenge. We will have feedback from all key opinion leaders and also from the lived experience on how to rise up to the challenge. We compile a document and then we would come out with a document which we will also do we'll come to a consensus on it and we can publish it in a scientific manner. So do all of you agree that we need to carry this forward? First thing is documentation. So publish it, and then once it is published, we can influence the media, we can influence the policy makers, and we can go about sensitizing policy makers in this regard. I apologize, we have carried this discussion a long way beyond what was mentioned, but I thought it was a very important discussion. So can I have just a brief comment from my friend here, Dr. Fazlul Haq, who was joined from Bangladesh. Fazlul, thanks for being here. Are you there? Maybe he's not. Yeah, Fazlul. Yeah.
I'm here. Sorry to.
I just saw your name and I couldn't resist not asking you to speak a few words.
It's a very good discussion. I was full time with your discussion. It's a beautiful platform and interacting and a lot of questions, discussion. I really enjoyed this discussion as a whole. You see, the problem are similar in our country and your country all the time. As we are working together, so far I can remember from 1995. So in Bangladesh, very short, the spinal injury center is only few centers. I can say only of this kind. So there are a lot of problems, lot of issues. It was discussed over here is very similar to our problem. So I'm totally agree with you and your discussion. I can contribute anything to this further development and preparing protocol or anything. I'll be more happy. So as the time is short, I'm not lengthening much, but I totally agree with you. That problem you discussed over here is the similar problem in our country as well. But what I can say is a more severe problem because we have very minimum spinal injury center and the spinal cord injury people in Bangladesh is very much neglected. So we need to do something at least for these deprived people. Thank you. Thank you again to offering me these opportunities to share with you.
Thank you, Fazlul. We will have repeated occasions on which we can take your input. So this is just the start. So we will have you to share your viewpoints on this platform subsequently. I see Dr. Sanjay Wadhwa has raised a hand. So Dr. Sanjay Wadhwa.
Just one sentence. I agree totally with your idea of doing some survey and coming up with a publication or a document. But my humble suggestion is that let us not let the meeting today go waste.
No.
So many people have expressed their point of view. You had a very structured program and so many questions, and these have been answered in their own way by various people. So my suggestion is let us publish this also. It will be useful. People who have not been able to connect with this function, if the message reaches them, they can also participate in a bigger event in future. That is my suggestion.
Definitely. We'll publish this as well. And in fact, this has been recorded. I will bother you, Dr. Wadhwa.
It will be my pleasure, not a botheration. It will be my pleasure.
No, we will record your initial part of the statement, and this will be on YouTube for all other people also to see, and we'll publish this also.
Okay.
So that would be great. Yeah, Shivjeet, you wanted to say something.
You see, I was just wondering, because ISICON will be there in November. Maybe that one particular session, because we all are here in a united voice, we can have one good session where we can invite one of the government from health ministry or whatever policy making bodies, and we should start right from now. Rather, we can do these, as you said, this paper and these things slowly, but we should, because advocacy means we have to have united voice. And I believe ISICON will be a good opportunity if everybody agrees to that.
Yeah, we will, a very good point. We will try to have a session on this during ISICON also. Hopefully, we may also have a manuscript ready at that time, but we can have like a consensus statement which could be put forward as a result of this consensus after the survey, and we could put that open to the forum during ISICON for discussion. Present it, put it forward for people to give their viewpoints, put it on the website, and let people give their viewpoints, and then publish that as well. So Dr. Bala had a point there.
So I just wanted to also say that I'm just seeing for the first time a lot of people from different parts of the country, both in NGOs and specialists, and professors from AIM. So it's a really very noble thing that you've gathered these people, and I think we need to communicate and talk more frequently. So I think in some forum, formally, informally, through email or whatever method, if there is more discussion about various things, maybe we could come to more consensus and conclusions. So Definitely. If you could make a forum, that'll be useful.
Definitely, this particular issue that we discussed today, we will carry it forward and get back to you soon, so that we have a consensus on this in a scientific manner and publish it. We'll carry it forward. With regard to this platform, as I told you, we'll have some discussion at least twice in a month, and everybody is welcome to join in. Our next session is already finalized. So we will take topics of interest to also persons with disabilities. So next session is on 4th, same time, 7 p.m. And the topic is wheelchair sports, right? And we will have the lead panelist as Deepa Malikji, who is today in the Paralympics committee, and we will also try to get a gold medalist from Paralympics join in the panel discussion, and another Paralympics participant join in, and people would be welcome to interact with them also during the session. I thought with the Paralympics creating renewed interest amongst not only persons with the disability, but also in the community, right? With them bringing more laurels to India than the able-bodied. I think it was a good time to initiate discussion in this regard. So what do you feel about it? Do you think it would be interesting and important?
Oh, yes.
Right. So mark your dates, 4th of October, 7 p.m. We will have this discussion. And if you have any viewpoints on how to make this more interesting and how to have a platform where there could be a continuous discussion, we will also create a platform where people, researchers, various stakeholders can interact with each other on how to improve the quality of lives, how to carry out research on each of the important aspects, education. And in fact, the Spinal Cord Society will also, executive will meet soon, where we will kickstart various committees in the society in these regards, which can also carry on work in this regard. So I think I would want to thank you all for staying behind despite an extended program today. I think it only shows the interest in all of you to deliver something to the society, to give back to the society, because all of us are there in a position today that we can influence the government, right? It is not me alone, it's all of us. The number of hands that we have, we can make a more important voice. Each one of us should use our contacts, our networking to the best to be able to reach out to the government, to the policy makers, and in fact all stakeholders, right? Like Dr. Bala did to the insurance company, we need to reach out to all stakeholders, I think, because there is a need, there is a potential, and yes, we can improve the state of affairs, we can empower, we can improve the quality of lives of not only spinal cord injured, but all persons with disabilities, so that we can say life after spinal cord injury can be happy, worthwhile, can be happy, meaningful, and worth living. And I think with this statement, we come to a conclusion for today's program. Thank you all once again. Thank you, panelists. Thank you, all participants. And many of you may be on the Facebook, have joined us on the Facebook. We can't see you, but hopefully we will have a platform where we can make it more interactive as we move ahead with time. So it's a start. Thanks for making it happen. I promise that we will live up to your expectations and carry it forward. Thank you.
Thank you, sir. Together we can.
Yes, we can. Thank you.
Thank you. Thank you all very
Thank you, sir.
Thank you, everyone.
Thank
you, Dr. Chabra, and my best wishes.
Thank you, Dr. Wadhwa.
Thank you very much, sir,
I think
for
we
a
need
wonderful
to thank
session.
each other. Together we achieve more, right? Together everyone achieves more. That is the teamwork, and we need to move forward as a team. This is our endeavor, right? And I'm just your face carrying it forward. Thank you. Thank you.
you, sir. Thank you.